you very much, Dr. Monroy, for that very comprehensive and obviously the work of an expert, no, in so many slides. Thank you, thank you. We would like to open now the floor for any questions from our viewers. Noneng, I will start with one.
Yeah.
Okay. I know you mentioned it already. Na before 20 or 30 years ago, we used to do copious lavage. Kailangan 10 liters
Mm.
until return flow is clear. What changed? No, there's so many things that I can think of now that we've already the practices have changed. One is
Mm.
irrigation versus just aspirating the how we manage the wound, whether we just keep it open or we close primarily, or to put a drain in. What has changed and what has been the evidence regarding this?
Well, one is the role of percutaneous drainage. Before, we don't refer to interventional radiology now, particularly for localized collection, post-operative complications. They usually are the first line, our interventional radiology colleagues. So that's one. Second is, of course, laparoscopic approach has been now probably standard in many guidelines, but there's a qualifier there. There's always that statement that there should be expert laparoscopic skills by the surgeons. So I think that's very important. And of course, the antibiotics have somehow changed. And I think the critical management has improved a lot. And the duration of antibiotics, although this is the most difficult part, we still practice longer duration of treatment. And although this is probably new updates that very strong in recommending 4-day duration, even for complicated high-risk intra-abdominal infection. And for now, I think that will take some time for the practitioners to change their practice.
We have one question from an internist. What are the more common pitfalls in antibiotic management of intra-abdominal infections that clinicians should avoid to prevent treatment failure or AMR?
I think number one is not following the recommended regimen, especially if your hospital has a recommended regimen based on your biogram or local patterns of resistance to antibiotics. So you have to follow. And then the timing of giving the antibiotics and the dose. So those are important. And I've seen cases where the culture was not followed up, and it showed resistance to the antibiotic that being given, and patient developed post-operative abscess or sepsis complications. So those are the pitfalls.
That was actually going to be the follow-up. Do you routinely recommend doing cultures? Because we've been giving these lectures and recommendations for some time already, but there are people who are resistant to getting cultures or following up the cultures in any
Mm.
manner. And second, corollary to that, would you cultures?
Well, anaerobic cultures first, it's not usually not routine. We have done that in some studies that I have participated. It's very, kumbaga, you have to collect specimen very meticulously. And so very technical in terms of yung anaerobic And we do not encounter much problems with anaerobic coverage. Another thing is most guidelines say that you don't collect cultures for low risk intra-abdominal infections. Well, that's true for hospitals or centers where they do their antibiograms on a regular basis. But if you don't have that data, then you should collect, I think. even for low risk complicated intra-abdominal infection.
I think we're fortunate that we work in institutions that have cultures that have a robust infectious disease specialty, but we know that we have colleagues and co-surgeons who work in hospitals with less resources, and I believe they also are challenged with the cost of doing cultures or the delay in getting the results. Because the
Yeah,
cultural results are only
very important.
useful if they come early.
If you get it within 24 to 48 hours, maybe
Exactly.
maximum of 72 hours.
Yeah.
Beyond that, it's
Not
probably
useful
not
anymore
useful.
to you. I wanted to ask you this. You gave the guidelines, and you made mention of this already, that I know it started with the Stop It trial that only 4 days of intravenous antibiotics are being given for complicated intra-abdominal infections. But of course, there are caveats to that.
Yeah.
No, and I think what everybody has to realize is, um, a lot of our colleagues, and I think from me also as a pediatric surgeon, we do hesitate to shorten the antibiotic therapy of our patients because we fear that our patient might have a relapse of the infection. So, what would those caveats be, and how do we navigate that so that we also follow the guidelines and contribute to the efforts on antimicrobial stewardship?
Well, personally, I can vouch for that guideline, mainly because I was fortunate to have participated in large trials in the 90s and the early 2000s involving complicated intra-abdominal infections. And during that time, even without that short duration of treatment guideline or recommendation, we noted significantly based on a discharge criteria or the discontinuation criteria of a febrile for 2 days, WBC back to normal, and patient's gut is functioning or a patient can eat, most of the patients will just require 3 to 4 days of antibiotic treatment, or 3 to 5 days at the most, majority. So we noted that even if the recommendation was really the usual 7 to 14 days, but with those trials, large volume of trials with Dr. De La Peña and Dr. Navarro, we established that. We know that already 25 years ago. So I believe in that recommendation. But you have to, yun nga, qualify, you have to use some criteria, clinical criteria like, yun nga, a febrile, gut is functioning, no ileus. And then if you want, you can check for the white count. So you have to combine it with some clinical criteria.
The sepsis guidelines include CRP always. And I noticed that it's a test that general surgeons are not very keen
Fun.
to use
Very
compared to orthopedic surgeons who use it all the time.
Yeah, I don't usually use it also. CRP and procalcitonin. Yeah, just
Yeah, we're
the
lucky.
white count and clinical, uh, in particularly the GI function and the signs and symptoms of sepsis.
Oh, there's another question here. Kindly confirm that this new guideline is recommended for low risk in uncomplicated acute appendicitis. The 24-hour IV antibiotic can be shifted to oral. I think you can answer that very well.
Well, the guideline is for
Complicated.
complicated, and therefore, although I did not include some of the guidelines for uncomplicated antibiotic, but the WSES guideline also recommends just one dose of pre-op, and if you see it's uncomplicated, then don't continue, or at the most for gangrenous appendicitis without rupture, 24 hours. Especially if you did a laparoscopic. So yun ang ano nila eh. One of the recommendation was if you did it laparoscopic, even for patient with abscess, localized abscess and phlegmon, you can stop after 24 hours of antibiotic treatment.
And I think that's one of the unsung values of minimally invasive surgery for appendicitis, that the rates of infection, SSIs, are really much documented to be much lower compared to that of the open procedure.
We have established that in St. Luke's for
Mm.
appendicitis. Um, Before we have a significant SSI rates when our lap appendectomy rate was below 20% or 10%. Now our lap appendectomy rate is 60% and the SSI rates both for complicated and uncomplicated is very low.
Mm. Good.
And we
Because
attribute that
also,
to
yeah.
lap approach.
Also with PGH, pediatric surgery, a laparoscopic first approach had been instituted in 2023 and really documented the rapid market decrease in the SSI rate with lap appendectomies. So we just like to reiterate that for uncomplicated, not ruptured appendicitis, a properly dosed and properly timed uh, prophylactic antibiotic, and we have the guidelines. The DOH has given the guidelines. Your hospitals probably have guidelines regarding the appropriate antibiotic to use.
As I think you mentioned very important is the timing of giving the antibiotic because we noted in some cases um, that at the ER patients are usually given IV antibiotics, but sometimes it takes 6 to 8 hours before you're able to bring up the patient, and you forgot to give
Right.
another dose. So you have to give with dose redosing within 1 hour before the start of your intervention, whether it's surgical or percutaneous. If you're if you're past 2 half-lives of your antibiotic.
Yeah.
So yun
Yes,
that's very important.
probably we're also alluding to a challenge, particularly those who practice in government hospitals where the caseload is high and there's often some delay in bringing up patients. So instead of
Yeah,
just giving a prophylactic dose, maganda nga yung slide mo kanina, and if with septic shock, you should do the definitive management
yeah.
in hours.
We can use that. I think we can use that evidence and guideline to
Yeah.
push our administrators that we're not doing standard of care now if we
Yes.
delay surgery for these cases. Even for low risk, complicated intra-abdominal, the time ngayon is 12 hours, within 12 hours. For septic patients, within 6 hours. So
Hours.
we
So
have to demand to our hospital leadership that that's the standard of care now.
yeah. We were using antibiotics as a stopgap measure. We can bring the patient up to the operating room. I had one question with you, to you regarding, um, how do you know? I know this takes expertise, and I hope the residents and training who are listening will get this. That after a certain level of number of years of practice, you will know which patient will probably get well already with just antibiotics. There's a patient who will get better with just percutaneous drainage, and there's a patient who will really need a definitive surgery, whether laparoscopic or open, to make him better. So how do you know that?
Well, base this is not really evidence-based answer. This
Practice-based.
this is personal experience. Although we know there's non-operative approach for acute appendicitis, and also even for complicated appendicitis with percutaneous drainage, but based on my personal experience, which is not very high volume, uh, failure from non-operative approach is very significant. We have, I can clearly recall 2 patients who had a localized abscess from perforated appendicitis, was managed with IV antibiotics and percutaneous drainage because of the recommendation in different guidelines. Both patients I have to operate after few days because of persistent pain and sometimes fever, even if the abscess is already drained. So maybe sometimes I think the tissues,
Or
there are
inflamed, no?
infected tissues or necrotic tissues that cause the persistence of symptoms. So I'm not really a fan of non-operative approach in particularly for appendicitis because evidence show um 40 to 60% reoperation rate, di ba? In 5 years. So, and in the recent guideline update, you give 4 days of antibiotics if for perforated appendicitis with localized abscess if you do percutaneous drainage. But for laparoscopic appendectomy, even if it's perforated and with abscess, you just give it 24 hours. So, which
Sulit.
do you think is
It's already
better?
sulit, di ba? The cost is already sulit and you use less
And
antibiotics to
yes,
contribute to the
yeah,
stewardship.
yeah, yes, yeah.
But
That's my bias, my personal preference.
well, that's coming from somebody who is who has access to laparoscopic, good
Yeah,
laparoscopic
yeah,
equipment,
yeah.
and who has the technical skills for that. So
Mm.
we know that many of our hospitals already in the Philippines are equipping themselves with
Yes. We
MI.
have a lot. I think we have very good laparoscopic surgeons, particularly
Yes,
general surgeons, and they can do even patients with generalized peritonitis. But this will require really a very, very good skill because you might have some retained
we've seen that
abscess
happen too. We've seen
past.
that
Yeah,
happen.
yeah.
Yeah,
If you don't do a good bowel run, a good check
the
of
cleanup.
all, yeah, all spaces, all quadrants. So it takes some skills, and you have to make use of the table positioning, movement, and even change
On
position
the
from
founders and trend and the
yes,
left and the right.
yes,
Okay.
and you have to have good bowel clamps, instruments, and yun nga, suction tip and irrigation, plus your monitor and camera should be very good in terms of resolution.
So maybe that's what we can tell our young colleagues here. No, don't scrimp. Don't scrimp on the equipment. I mean, to be able to do good surgery, you also have to have good equipment.
Mm,
It's not enough that the surgeon is excellent. Everything else has to follow.
mm,
But I just realized that we should be doing research through the Philippine College of
yeah.
Surgeons regarding the duration of treatment for
Mm.
intra-abdominal infections. I think we have to do our part in antimicrobial stewardship. No? There is already a lot of evidence. All we have to do is follow the evidence and create our own evidence. And maybe eventually we can even lower the cost of our management.
Well, I
Of
mentioned in my lecture that each hospital should really analyze their data for intra-abdominal infection, not only for the antibiogram, maybe the treatment duration, and the complications, outcomes. So that is very important.
I just noticed your two cases, the second and the third case. You were very confident in doing the laparoscopic sigmoidectomy with primary anastomosis, and the patient recovered without a glitch. Whereas the other patient on whom you did an anastomosis also developed complications,
Yes.
which really required you to do
Well,
a
the first case
glitch.
was my case. The two other were not, but from my colleague. But I have to ask or borrow those cases for learning because of the
Yeah. But my
complication.
last question was, what was the difference? So yes, you would agree. Maybe the patient had other comorbids. What were the conditions in the abdomen that probably were contributed to the anastomotic leakage? Was there discrepancy in the bowel diameters? Was the both were stapled anastomosis, right?
Yeah.
So that would have
So
that's
for
the
I think there's also some technical pearls in doing laparoscopic approach for intra-abdominal infection, particularly for ruptured appendicitis. Yeah, I emphasize that when you have fecalates, make sure that you are able to remove those fecalates. They go out of the appendix, and if you leave them, that will be a cause of abscess.
We've seen two or three
Yeah,
cases
yeah,
of
yeah.
that.
So you
That's
have to check the specimen. If there's, if you identified a fecalate in your imaging and then you did not find a fecalate in your appendix specimen, So while still doing the procedure, you have to look for that. Sometimes by luck, I was able to find alpicalit in the subhepatic area.
The ficalet was showing itself to you. It's opening itself up to you.
Maybe because of good system
Run.
towers, good
Uh,
good laparoscopic camera
very nice.
quality.
Yeah, I think that's very important when you're doing laparoscopy, no? That to be able to examine the entire abdominal cavity in the presence of generalized peritonitis. What would be your indications for doing a CT scan, for example, for patients with intra-abdominal infections?
Well,
So many
for
patients ask for CT scans, you know. So when you say it's not needed and when you say it's really needed, you know, mommy.
it depends on your hospital eh. If we based on guidelines, international guidelines, they will all studies show that gold standard should be CT scan with contrast. In St. Luke's, we do plain CT scan within 30 minutes. We're able to do it within the hour. So very convenient and very helpful. So CT scan, I think we for appendicitis we can uh we can avoid or defer. We don't need a CT scan or a routine CT scan in appendicitis. In some cases where for diverticulitis you need it
Probably
because
yes.
even if the presentation is sometimes acute abdomen, generalized pain
Okay.
and tenderness, the abscess is just localized or sometimes it's just inflammation of the sigmoid. I think if your clinical impression is diverticulitis, you have to request for CT, even plain. If in your setting, you cannot request it at an early, kumbaga, timing or schedule, then you can just go clinical. Some with good sonologists can also identify bowel pathology and fluid collection.
Even with ultrasound.
Yeah.
Okay. I think we have I think we've exhausted the questions here. Thank you very much, Dr. Monroy, for this very instructive. No, we learned a lot from you for
What
this
my
webinar.
my take-home message is try to read and really study the different guidelines. They're too lengthy. One guideline, I think, is almost 30 pages. So, and there are maybe 6 guidelines in intra-abdominal infection. So, if you can read them all, that will be very.
The the PISMID, the Philippine Institute Society for Infectious Diseases, is actually we're participating in the creation of the surgical prophylaxis guidelines.
Mm,
But we have all these guidelines that we come from abroad, usually from first world
yeah.
countries. And the challenge is how to apply these guidelines from first world countries into our local setting because oftentimes, the tests that they ask for are way beyond the PhilHealth case rate package, way beyond any HMO coverage. And that is a challenge for our patients now financially. So this is probably a plea for us in the surgical field for
Yeah,
those in
that's
CS.
why
No?
you still have to be very sharp in your clinical diagnostic skills, and it
Yes,
is justified to operate on a patient even without imaging. And also if your imaging does not say or confirm that you have an intra-abdominal infection.
yes.
So that's a very important dogma. You can operate if clinically and you
A
think
surgical abdomen.
oh
It's a surgical
there's
abdomen.
something that's wrong inside, even if your CT scan is negative, then you're justified to open.
Thank you. Thank you, Dr. Monroy. I
Thank
think we
you.
can conclude this open forum. So we can give our certificate of appreciation virtually, of course, Dr. Monroy.
Thank you.
And may we flash the certificate? No? I hope our residents were listening. This is a very, very important topic. And we know that patients have succumbed, have had morbidities and mortality. We've had morbidities and mortalities because of difficult cases. No? So it's very important that we arm ourselves, no, both with the technical skills and the knowledge about antibiotic usage, no, to make sure that our patients get the best of care. So the certificate is here and it reads, can you flash it? Oh, it's not running on my side. The certificate of appreciation from the Philippine College of Surgeons, it's jumping. And by the Committee of Surgical Infections and the Philippine College of Surgeons Foundation, on this webinar, being the speaker, Navigating Challenges in the Management of Complicated Intra-abdominal Infections, is awarded to Dr. Hermogenes Monroy for his invaluable participation as a speaker, given today, September 20, 2025, virtually via the Docuity platform. Thank you very much, Dr. Monroy.
Thank you, Dr. Saguil, and to PCS and to Pfizer. Thank you very
Thank
much. And
you.
to Docuity.
And of course, the MC and the moderator is required to also have a certificate. And my certificate is flashing now. Thank you. The certificate is signed by the regent in charge of PCS, Dr. Domingo Bongala Jr., and Dr. De Leon, the president of the Philippine College of Surgeons. So I think we can already flash the next slide, please. For those who attended, this webinar has 2 CPD credits accredited by the Professional Regulations Commission, or PRC. However, to earn the credits, you have to complete the post-test on Docuity and the session evaluation by the end of the webinar. So please do that. So to end this webinar, we will be given the closing remarks by the Vice President of the Philippine College of Surgeons and the President of the PCS Foundation Incorporated, Dr. Joselito M. Mendoza, also a general surgeon and minimally invasive surgeon. Dr. Mendoza?
Thank you all for joining us today for our webinar on navigating challenges in the management of complicated intra-abdominal infections. We are grateful to our speaker, Dr. Noning Monroy, for sharing his insights and experiences. It's been a great learning opportunity for all of us. Managing these cases is never easy, but sessions like this help us stay sharp, updated, and connected. Thank you as well to everyone who participated and asked questions. We hope you're taking away practical tips that you can apply in your own surgical practice. Stay safe, keep learning, and we hope to see you in our future endeavors. Have a great day.
To the PCS Foundation, to our speaker, Dr. Monroy.